So welcome everybody. My name is Dr. Bren Kelly, and today my colleague Jessica Warnell and I will be talking about the early detection of eating disorders and considerations when working with students with eating disorders or disordered eating. Thanks, Jess. So before jumping into disordered eating, though, we thought that we would give an overview of normal eating because we need to know what's normal before we can determine if it's a problem. So when we think about normal eating, one of the first pillars relates to our hunger cues, in that we eat when we're hungry, we continue to eat until we're satisfied, and then we stop when we're full. Another aspect relates to choices and preferences. So we select things that we enjoy eating, like birthday cake, and eat a normal portion of it, or even have a bit extra because we like it. And of course, that doesn't mean that, we eat cake and we only eat cake. So we pay attention to general nutritional guidelines and make sure that we eat things from different food groups, but we're not overly rigid about it. So we'll add some veggies to our dinner, even if they're not our favorite, because we know that they're good for us. But we won't have a dinner of all veggies, and we allow ourselves to have that cake afterward. Another thing that's quite normal is to sometimes eat not just because we're hungry or need nutrition, but because it makes us feel good and meets an emotional need. So maybe we go out for a special treat when we get some good news and we want to celebrate, or we turn to a comfort food when we're sad, or maybe we mindlessly snack a bit to stay awake while we're studying for a test. In terms of the pattern of our eating, we may eat the recommended 3 meals plus a couple of snacks, or we may choose to graze on bigger snacks or smaller meals all day long. So with normal eating, the amount might also vary in that sometimes you eat more and sometimes you eat less, depending on your cues and your cravings. So sometimes you may even overeat to the point of feeling stuffed, like we do on holidays, or maybe when we're eating a favorite meal. And sometimes we may undereat and wish that we had more, like when you only grab something small for breakfast when running out the door in the morning. Generally, though, with normal eating, you are listening to your body's natural cues and you're trusting that things will even out. So if you underate for breakfast, then you'll get hungry and eat a mid-morning snack. And if you overdid it on the chips, you may feel full and take a break from them, or crave some fresh produce to balance things out nutritionally. And although thoughts about eating and nutrition may take up some of your attention, normally this would be only one of many different things that are important to you, and it wouldn't take up all of your attention. So overall, it's normal to have variability in what, how much, and when we eat. And this isn't a big deal because overall it balances out as long as we're not ignoring our body's cues or following any overly rigid rules. So certain situations, though, may interfere with normal eating. So for example, teens might ignore their hunger cues at lunchtime because their friends aren't eating, or because there's an activity that they want to join in on. They may also then adjust for this missed meal by having a meal-like snack when they get home from school, or even overeating after school because they're so hungry that they eat quite a bit before their fullness cues have a chance to kick in. On the flip side, skipping meals can also disrupt that mind-body link and our brain's ability to register and act on hunger cues. And this can lead to further restriction because this link is disrupted. In addition, skipping meals for benign reasons may then lead to a desired outcome, like weight loss, which can then trigger intentional skipping of additional meals and snacks in an attempt to lose more weight. So teenagers' normal eating might also get disrupted if they start comparing how they look or eat with their peers and want to mimic or fit in with their peers. And sometimes normal eating might also get disrupted as teens learn more about nutrition and health. They may try to make some changes to their diet or activity level that they view as positive, or that start off as positive, but then actually derail them from what would be considered to be normal eating. So they might start off by trying to improve nutrition in their diet and to eat treats in moderation, and then move to cutting out all desserts or setting a restrictive calorie limit. So children and adolescents could also move from normal to disordered eating due to body image triggers. And these body image concerns may be triggered by constant access to social media and exposure to unrealistic ideals about weight and shape. Youth might also compare themselves with peers who have different body types and feel triggered by those differences and not understand that this variation in body types is natural. And this can be especially difficult during puberty because there's a lot of changes to teens' own bodies and those of their friends. And teens may want to try and use eating and exercise to try and control this process. Youth might also experience some initial weight loss or thinning of their shape and then receive positive feedback about these changes. And this praise can actually lead to overvaluation of weight and shape and reinforce the thinness ideal and also imply that weight and shape is under their control and maybe should be under their control is what they might think when they get that feedback. So for some youth, this might trigger further focus on trying to control weight and shape. On the flip side, some youth might be triggered by having others bully or otherwise draw too much attention to their natural body size or some weight that they had put on. And this can lead to self-consciousness about their size and can trigger disordered eating. So warning signs that a youth might have an eating disorder include intense fear of weight gain, valuing body weight and shape above other things and overly focusing on it, having unusual rituals or rules around food and eating, refusing to maintain a healthy body weight, binge eating, purging food that they've eaten by vomiting, excessive exercise or other methods, obsessively reading food labels, eliminating foods from their diet that they used to enjoy, continually making excuses about why they're not eating, or claiming that they have a sensitivity to a food that they previously ate, such as a sudden intolerance to dairy, meat, or gluten. So people often ask us what the difference is between disordered eating and an eating disorder. And basically what we'd say is that disordered eating is eating that may be concerning, but falls below the threshold for what would constitute a full-blown eating disorder. So to qualify for an eating disorder, you have to meet specific criteria in terms of the number of symptoms that you have, the severity and frequency of those symptoms, and how long you've had them. When youth meet criteria for an eating disorder, then they would need to be referred for an evidence-based treatment with a therapist that has experience treating eating disorders. But if they don't have a full-fledged eating disorder but have disordered eating, then they may benefit from less intensive services or supports to help them get their eating on track and to prevent the development of an eating disorder. So I won't go into all of the details of the criteria for different eating disorders, but we can kind of give you an overview of that. And this slide gives you an idea of what the different eating disorders that can be diagnosed with the DSM-5, which is our diagnostic manual. The diagnoses that we most often see for children and adolescents in our clinics are anorexia nervosa, atypical anorexia, bulimia nervosa, binge eating disorder, and ARFID. And some of these diagnoses you may already be familiar with, but I'll give you just an overview of each to illustrate some of the defining features, the areas of overlap, and some areas of difference between them. So anorexia is a really well-known eating disorder and is associated with an intense focus on low body weight and thin shape, leading to restriction of food intake and significant weight loss or failure to stay on their growth curves, and not acknowledging the severity of that low weight. So anorexia often includes other eating disorder behaviors that are aimed at controlling weight, such as compulsive exercise or vomiting, and can even include binge eating at times that's triggered by extreme hunger and craving from starvation. There are a number of medical complications that are associated with anorexia nervosa, and it's more lethal than some childhood cancers. So teens with this diagnosis really need close monitoring. Atypical anorexia is very similar to anorexia nervosa, but is a diagnosis that's given when teens and youth are within the average weight range, despite having significant weight loss. So these are youth that naturally tend to have a higher set point for their weight that's healthy for them. So they may look like their average weight after their weight loss, but they're actually not healthy at that lower weight, and the way that they lost that weight isn't healthy. So these youth can be harder to spot because you can't tell that they're ill just by looking at them, but they can actually be just as risky medically as those with classic anorexia nervosa. Bulimia nervosa is another well-known eating disorder and is associated with periods of binge eating that are followed by behaviors aimed at purging that food that's been eaten, such as, so purging would mean things like vomiting food after eating it, or trying to exercise to burn calories. Whereas anorexia is characterized by over-controlled eating, bulimia is characterized more by lack of control, followed by behaviors that are designed to gain back some control. So children and teens with bulimia, they tend to be of average weight or even slightly overweight due to their kind of yo-yo dieting and eating, but can also experience some big ups and downs in weight, depending on how much they're binge eating or how much they're engaging in those compensatory behaviors. And these behaviors can also cause a number of really serious medical problems. Binge eating disorder is similar to bulimia in that there's a significant problem with binge eating, but it differs in that there are no follow-up behaviors after the binges to try to compensate for it. And as a result, significant weight gain can occur, which can lead to other health problems. A final eating disorder that I'll mention is ARFID, which stands for Avoidant Restrictive Food Intake Disorder. ARFID is a newer diagnosis in the DSM, and it's one that tends to be referred to the feeding team or to community mental health at the IWK rather than to the eating disorders team. And that's more because of the way that you treat it. So like anorexia, ARFID can involve severe food restriction that leads to significant weight loss or growth issues. And as a result, it can be associated with really significant medical risks. The difference with ARFID, though, is that the food restriction is not driven by a desire to lose weight or a fear of becoming fat. It's associated with other forms of anxiety, such as aversion to certain textures in food or fear of unpleasant physical sensations when they eat, such as acid reflux. And it could also be related to long-standing sensory issues or picky eating, or might be brought on by a conditioned response to something unpleasant, such as food poisoning, that then leads to a fear of vomiting after eating. So in terms of treatment for eating disorders, our first line of treatment is family-based treatment, which was originally developed for anorexia nervosa, but then expanded to include bulimia nervosa, and then can also be adapted for atypical anorexia, binge eating disorder, and sometimes ARFID. There's been a lot of research demonstrating the effectiveness of family-based treatment that we call FBT, and it's considered to be the gold standard for children and teens. So FBT is an outpatient treatment which is led by a therapist and also includes a medical team consisting of a physician, a nurse, and a dietitian. And the therapist is considered to be the lead of that team that coordinates it. And FBT is really focused on empowering parents to address the eating disorder behaviors that are life interfering. And it's very practical kind of treatment. So although it incorporates some elements of family therapy to help parents be successful with managing the eating disorder behaviors, it doesn't delve deeply into family issues the way that some other kind of family therapies would, and only addresses these issues if they're treatment interfering. So we're not focused on what went wrong that led up to the eating disorder, and we don't spend a lot of time kind of focusing on the cause. Instead, we're really focused on what the family can do now to come together to bring their child back to health. So FBT has 3 phases, and I'll just give you a brief overview just so that if you ever have students that are in treatment, you kind of have a sense of what they're doing. So the first and most intensive phase is phase 1, and that focuses on weight restoration. And this is where really the bulk of the change happens and where most sessions are focused. In this phase, parents are completely in charge of the what, when, where of their child's eating, and the therapist supports them in taking this on and figuring out what strategies are successful in interrupting the eating disorder behaviors, getting their child to eat, and promoting weight gain. The second phase of FBT really focuses on returning independence to the teen, and we move to this phase once parents have made significant progress with getting their child to gain weight, and their child is no longer resisting their parents' efforts at renourishment. So they're compliant enough that we think that they could benefit from getting some independence. And over the course of phase 2, we gradually hand back that independence with eating and physical activity. and the parents, they're kind of gradually stepping back, and we support them in that. But they can also quickly step back in if their child doesn't handle that increased independence well. And once, though, they've reached a point of full independence and they're successful with that independence, then they're ready for phase 3 of treatment. And this final phase of FBT focuses on getting the family ready for termination and ensuring that the teen is back on track developmentally, because having an eating disorder can really be quite isolating and kind of get you off track in a lot of ways, with friends, with academics. So we typically transition to this phase when the teen is, they're completely weight restored, or maybe they're almost fully there, but they don't have any eating disorder behaviors left. So now that I've kind of given you that overview, I'm going to turn things over to Jessica, and she's going to discuss the impact of eating disorders and disordered eating on mental health and academic functioning, and she'll provide some tips for how to support students.
Thanks, Bryn. So now that we've overviewed the different types of eating disorders, it's important to think about how poor nutrition can lead to difficulties in the school environment. So that's why it's so imperative that if teachers or school plus workers are noticing differences in a student's ability in the academic setting, to discuss with the student what might be going on. So it's really common for a student to start having difficulty concentrating, and you might notice that they may start to struggle with things like memory and recall. And this is often due to them having things like preoccupation with food, or eating disorder rules, but also can be from just not having enough overall nutrition. So we also notice that patients have lower mood and anxiety. And in fact, what we've noticed is that often if you treat the eating disorder, like with a therapy like FBT, what seems like primary mood or anxiety symptoms might actually go away completely or significantly decrease as nutrition is reestablished. So as mentioned before, some of the issues with memory and recall can be caused by things like preoccupation with thoughts about food, calories, and nutrition, but also starvation syndrome can occur, where the body actually has really amazing ability. Our body's very smart. And when somebody's not eating enough, our body actually makes us think about food even more. And that preoccupation can intensify with somebody with an eating disorder. So as restriction continues, it can be very overpowering and sometimes can be actually quite disruptive for the youth who's struggling. Cognitive distortions are when someone doesn't view themselves accurately. So this can greatly impact participating in things at school because they may feel ashamed or embarrassed of themselves for being what they think is too big, and can be very distressing for them to do things like a presentation in front of a class, for example. We always kind of talk about, like, it's almost like somebody with an eating disorder, when they look in the mirror, they see somebody that's quite big, but if we were standing behind them, we would see somebody that's actually quite thin or underweight. And the way we often describe that to our patients is kind of like if you're at the Discovery Center and you're looking in those mirrors that can kind of distort your body, their brain is actually doing that to them, and it's quite real for them. So you might notice that students get very rigid with things like rules, and that can be, it could be things like when they need to exercise, when they need to go to the bathroom, at what specific time they need to eat. And they can get quite irritable if those rules are getting broken because they feel like they've failed their eating disorder or they've done something wrong. So with all this, you might notice things like increased irritability, fatigue, interrupted sleep patterns due to some of this over-evaluation that's happening in their minds. So we pulled some information. There's an amazing toolkit out there, and it was released by the National Eating Disorders Association. And they've put a lot of thought into the impact that eating disorders have on the functioning in the school environment. And this is actually a toolkit put out there for educators themselves. And so it can be quite helpful. And at the end of the presentation, you'll see a link in which you can access it. But developmentally, there can be significant effects on development in children when there's not adequate nutrition. So these are years when the child's brain is forming and they're developing. So not having adequate nutrition can actually delay development. As noted before, having an eating disorder can create changes in behavior and school performance, disrupting their focus. And there can also be a lot of side effects that come with it. So they may be noticing, due to their lack of nutrition, that they may have things like nausea, headaches, cardiac symptoms, such as dizziness, chest pain, and overall they may just feel very, very lethargic. So I like this next point as it speaks to not only those with eating disorders, but also those who are dieting. So we know that that's actually quite common amongst teens. So when academic performance is decreasing, it might be important to explore, what are some of the fundamental things that are getting in the way of maybe their academic performance. So we know that people need their basic things like sleep, shelter, and nutrition. So even your students that are dieting, you could actually see impact on their overall functioning at school. So this next point that AnITA makes is one to also focus on. People who are struggling with an eating disorder often have a harder time seeing kind of the big picture and can focus on tiny details such as eating disorder rules or counting every calorie, or maybe a small part of a project or a theory, but actually might have difficulty adapting to the bigger concept. Or see kind of the overall impact that some of the behaviors have on their overall functioning. So when we're thinking about bigger concepts, so it's not only in their eating disorder, but also in the school environment. So they might have a hard time actually completing a project or understanding broad concept. Perfectionism and obsession with good grades is extremely common in people with eating disorders. Often it's high achieving, goal-directed students who tend to struggle. They may become overly rigid with their schoolwork and grades, but it might take them 2 or 3 times as long to complete tasks, not allowing them time to do anything else. I actually once had a patient who was so rigid with her schoolwork that she was waking at 3 a.m. to get her work done. She couldn't be disrupted. She was extremely irritable. And she actually even stood all the time when she was doing her work so that she could be burning as much energy as possible while still trying to uphold her high academic goals. So for her, like anything less than 100 was a complete failure, and she would become incredibly emotional over even the smallest of errors. One thing we also noticed with her and with many of our patients is they might actually do work over and over again. And they may be overly focused on trying to please their teacher or their family, especially if they always were very successful in school, also to try to cover up the eating disorder and pretend like there's nothing going on. Eating disorders are very, very secretive illnesses, and often there's a lot of effort put into keeping it not known. So as mentioned before, increased depression and anxiety can also occur. And you might notice a student may be more withdrawn. They can't keep up with social relationships. They might start isolating from their friends or teachers. So it's just important that when you're noticing these changes that you kind of think, why are these things happening? Nutritional deficiencies can also weaken their immune system, and students might just start to get sick more often, which can lead to, of course, missed time. In addition, students might also miss time due to treatment requirements. So in FBT, it's weekly therapy, and there's also a medical monitoring component, and they also might need to miss school if there's a significant amount of eating disorder behaviors that parents are addressing through either their meals at home or through just general supervision. So I really like this quote that AnITA had out in their toolkit. So I think it really just speaks to, despite them being malnourished, the perfectionistic attitude of those who suffer with anorexia or bulimia may actually compel them to maintain a very high level of academic performance. So a student with a life-threatening eating disorder may actually continue to earn all straight A's despite being acutely ill or maybe even on the brink of hospitalization. And for individuals with eating disorders, functioning can also be asymmetrical. So in some areas, such as schoolwork, they may be less affected, while others, such as health and social functioning, as I mentioned before, are affected greatly. So it's just important to remember that academic performance is not a good measure of an eating disorder's severity. So let's talk a little bit about some common adaptations that may be needed in the school environment. So some of the biggest things that we actually think are important is decreasing the workload. So we know many of these students are actually very good students, and it's important that this student be able to actually put the treatment first. So you may want to consider what's necessary and decrease work given or give extension so they can focus more on their recovery. One other thing that we often make recommendation around is health class. So health class is one class that we often get students excused from, especially if the focus of the content or there's modules on things like nutrition, exercise, and body image. They might actually need to be excused for a period of time because it actually could provide some mixed messaging with their treatment. For example, if you are discussing something like healthy eating and emphasizing that decreasing junk food is good, or something that students should focus on, that could actually go against what we're recommending in treatment, which is to reintroduce all foods they would have eaten prior to the onset of their eating disorder. So for many people, their fear foods are some of those less healthy, what we consider less healthy food, maybe something like chips, but we actually need them eating those things in order to recover. The other piece to keep in mind is because of the medical components, as well as psychological components, patients in treatment, especially in the beginning, are often not able to engage in physical activity. So even something as light as yoga is often not permitted. So in eating disorder treatment, you actually have to interrupt anything that the eating disorder is connected to. And it's often tied to exercise, like needing to exercise a certain amount to burn energy, or even that unnecessary standing. And also, in addition to those behavioral pieces that have more to do with the cognition and burning off energy, there also may be many health implications with eating disorder treatment in which they need to not be physically active. So sometimes being physically active can interrupt weight restoration. So if we're trying to get them to gain weight, and then they're still being physically active, they often are in a state of what we call hypermetabolic. So they're burning through everything really quickly, and weight loss can intensify. Or just in general, being physically active can have a lot of cardiac side effects. And we know in eating disorders specifically that there's a lot of cardiac functioning problems that can occur, and we need to stabilize their cardiac functioning through refeeding in the therapeutic process. So as a member of the school staff, you actually might be asked to support a student or supervise a student's snacks or lunch. And this is what we call meal support in treatment. So during this time, it's nice if you can actually eat with the youth to normalize eating and not just watch them. But it's also important to not have any distractions and pay close attention to the youth during this time. It's nice to talk about things other than food during the meal to distract them, but it's not your job as school staff supervising to force them to eat. If they end up not finishing and you are supervising them, then you should just immediately contact their parents to let them know that the youth was unable to eat in the school environment. And then maybe it may be possible for the parent to pick them up if that were the case, as in this case, it's kind of like food is their medicine, and the proper doses do need to go in at the right times. So parents often will kind of prioritize getting the food in over them staying at school for the rest of the day. It's also possible a parent may also ask you for a private space to be able to eat with their child in the school environment. If this isn't possible, because we know space can be limited, sometimes parents will come and eat in the car with the child, and then they'll return to school after they've completed. This is something that one of the doctors that Dr. Kelly and I work with calls the tailgate lunch, where they will eat in the car and then head back to school. But the parents do have this commitment to make sure that all the meals and snacks go in. It's important, as somebody who works in the school system, that if you notice any behaviors that stand out, to report them to the parents. So things like hiding food, crumbling food, smearing food, spilling food, maybe spitting or asking to go to the washroom directly after eating. Maybe they're standing unnecessarily, or exercising in class, maybe even discreetly. All these things can actually be part of an eating disorder. And it would be important for the parents to know that these things are occurring in the school environment. Again, it's not really your job to disrupt these, rather than just make observations and report it back to the parents. So this is a tricky subject. So a lot of people ask us, like, when do you notify parents? What about breaking confidentiality? So this is something that many professionals struggle with when discussing eating disorders. Often as a mental health clinician, we want to protect our patients' confidentiality. And one question we often are asked is, when do the limits of confidentiality come into play when you're working with somebody who has an eating disorder or discloses disordered eating symptoms to you? So we've spent a lot of time talking today about the negative impacts of poor nutrition on a young person, from the cognitive impact to the impact on their physical health. So it's important to really remember that poor nutrition can lead to many health consequences, including cardiac instability. So we want to consider that eating disorders actually have the highest mortality rate of any mental illness. So just as many people die from an eating disorder as do from some common cancers. It's like a 1 in 5. So we don't always know the medical impact of the eating disorder when we're just talking to the student in conversation. So it's important that youth get a medical practitioner as soon as possible to know actually the medical implication that their poor nutrition has had on them. So one of the biggest indicators for treatment response is early intervention. So the earlier an eating disorder is detected, the easier it is to treat. So it's important to consider that in making your decision to break confidentiality, that you're considering that there could be actually a risk of medical deterioration, that ongoing nutritional deficiencies could actually lead to a cascade of other medical complications, as well as further weight loss. And with the further weight loss can come things like dehydration if they're not getting adequate fluids and nutrition in, and that can lead to significant problems with things like electrolytes, and electrolytes directly also impact cardiac functioning. So you can see, like, I use that term very specifically, like cascading. It's one thing after the other, or a bit of a domino effect that can occur. So we would recommend, if you suspect that there's an eating disorder, that you breach confidentiality for this reason. Sometimes it can be helpful to think of it like risk of harm to self. We're used to kind of dealing with that, knowing the risk of deterioration or knowing the risk of harm to the youth. And often in eating disorders, they actually lack a lot of insight or motivation to actually change. And so it's important for caregivers that they're aware, especially where there's so many medical things that can occur. So for youth, we really do want them to get the appropriate medical intervention, and that phone call could actually save their life. So NITA has put together some really good suggestions on how to approach these conversations with families. So it's important to show empathy and support, of course, when you're having these conversations with family members. So you want to give them the information without judging them or making any promises. You want to be able to balance being supportive and empathetic with concern and a serious tone. This is something we do as therapists all the time, really trying to validate and give them a lot of emotional support, but also letting them know this is serious and we need to take action on it as soon as possible. We want to be able to aim to establish and maintain a positive, open, and supportive relationship with parents and families. But we have to really be mindful that sometimes parents can feel extremely guilty or blamed, and sometimes they can really feel responsible that the eating issue or disorder is because of something they did as parents. And we really want to, and the treatment itself actually really aims at this, try to take that myth away that parents didn't cause this. It's nothing in their parenting strategies, or it's nothing in their environment that created this. Eating disorders are often a perfect storm of many things that come together that can really impact their overall functioning. And usually there's many different factors and we don't really know why eating disorders happen, just like we don't know why people get cancer. You want to begin by telling parents and families that you're worried about the student, and offer a lot of specific and factual observation about the student's behavior to illustrate your concern. So try not to interpret what the behavior could mean. Like, you don't want to say, like, I noticed that she's going to the bathroom after every meal, so therefore she's purging. You just want to give the fact, like, she's going to the bathroom whenever she eats, and I'm worried about, what that might mean. Do you notice that at home, type of thing. Don't make or suggest a diagnosis. So don't kind of say the words eating disorder until as you heard from Dr. Kelly, eating disorders are actually very tricky to diagnose, and you really have to meet a very certain criteria. And the diagnosis can often depend on what we offer for treatment. So it's important to not suggest a diagnosis, but rather just say that you're worried about these patterns. And you want to stay calm and, of course, stay focused on the goal of the conversation. Remember why you're having the conversation with the family. It's ultimately to help this student with their problem and try to improve their academic performance. And overall, really, the more important piece is their quality of life. The eating disorder is kind of taken over. And so we want to help them get back to themselves as soon as possible. You want to encourage the family, of course, to access support and information. And you want to give them information on how to access service. And we will talk to you a little bit about what to do and how you would access service if you think a student has an eating disorder. You might also want to give them things like mobile crisis or kids help phone, and just kind of be mindful to all of the different options that they might want to explore. You don't want to persist with a conversation that isn't going well. So sometimes when you do have these conversations, sometimes parents could feel defensive or they might be really upset. So you don't want to keep going with a conversation if it's not going very well, because it could really damage future communication with the parents. And you want to keep those lines of communication open, as it'll have the best kind of impact for the youth that you're working with. So that brings us to kind of like, how do you actually access service? So it depends on where you are in our province. So If you are a staff that's working within our Halifax Regional Municipality and your patient lives in HRM, then they can call the IWK Central Referral. So IWK serves just our HRM patients, and the phone numbers there are listed. So there's the 1-800 number where you can call the direct line. But at the same time, you actually want to encourage the family to also make an appointment with the family doctor. Remember the medical seriousness. So we really want to make sure that they're getting assessed as soon as possible. If there's a lot of really serious medical consequences that the youth is reporting, you can, of course, always recommend that they go to the ER. That's never a bad recommendation. You know, if they fainted or they're complaining of a lot of chest pain, and we're really unsure, they're not able to see their family doctor, then of course that recommendation would be great. But the great thing about going through central referral is, like, if you know, as Dr. Kelly was saying, is eating disorder or disordered eating, central referral can ask some really skilled questions around, does this meet full criteria to go to our eating disorder specific care clinic where Dr. Kelly works? Or is this something that actually is more disordered eating and could be addressed in our community mental health clinic through something like a choice appointment? So it gives you kind of some options, and central referral is quite skilled at being able to determine that, as is our case managers in that clinic there. If you are from outside HRM, we actually have access to the same level of service. So the patient or family can call central referral for intake. So they can self-refer, or the family can refer them, or the family doctor could refer to the local mental health clinic or central intake for assessment. So essentially it goes to wherever they live locally, and there's clinicians trained across our province in the same therapy that they are trained at the IWK. So there's kind of two ways for youth to access care, but certainly very similar patterns and same access to service.
And Jessica, I'm just noticing that the folks that are on today seem to be from the Western Zone. So the Tri-County, so Shore and the Valley.
Okay, great. Yeah, Western Zone has quite a few skilled clinicians and clinicians that are trained up in family-based treatment. So there's a couple clinicians in the actual Valley area, so out of Chipman, as well as we have quite a few in South Shore. So there shouldn't be a problem with access to treatment in those areas. So we'll turn it over for questions, and you'll see the link for the AnITA Toolkit. There's a PDF version there, and there's lots of great information in that resource. But we'd be happy to have discussion, answer any questions that you guys might have. We tried to reserve 15 minutes for that.
Could you maybe put the link in the chat as well? It might be easier for them to catch it.
Try to do that.
Thanks.
Maybe I'll stop sharing here, and then I'll link it into the chat.
And I can tell you one of the questions is, what about families who do not have a family doctor?
Yeah, great question. It's a tricky one too. Something we're certainly trying to work on. So for families that don't have a family doctor, and are you outside of HRM? I'm assuming.
Yes, they're in the Valley.
In the Valley, yeah. In HRM, we do have a partnership with one of our family doctor clinics. But in the Valley, you could use a walk-in service, you know, to be able to get those first steps at medical assessment, and then also the referral to the mental health system. Unfortunately, we don't have a great answer for it. And, you know, perhaps there's some more kind of work that we can do with that piece around accessing primary care in rural Nova Scotia. We know that that's difficult. We've trialed a partnership at the IWK with Dow Family Medicine. It's worked very well. So if you come into our service, you might have to access a walk-in doctor first to get in. And then once you're in, then we can connect you with a family doctor through Dow Family Practice. It's a bit of a collaboration that was created there, but perhaps we can look at that model and see, can we do that in more areas across the province? We're rolling out a whole new, essentially, program for eating disorders provincially. And so that primary care is a big piece of that outreach that we're going to be doing.
Great. Another question is, I work with elementary age children. Are there issues more common in young students now?
That's a good question. I mean, Jess, you can probably handle that since you used to do manage all of our referrals. But certainly my perspective is yes, we've seen more of an increase with younger children.
Yes, definitely over the last kind of 6 years. I just recently moved to this position with the province, but you know, over the last 6 years, I'd say that like we used to see like maybe one a year, and now like the population does seem to be getting younger. Lots of like in the range of 10 to 12, certainly, but as young as like I think the youngest referral we've had probably in the last 6 years would have been around 6 years old. So it's happening at young ages, and why it happens, we're not really sure. But certainly I wouldn't cross it off the list if there's some concerning signs at those young ages.
And sometimes, Jessica, I think we've seen too when there are those young ages that there's some comorbidities involved. Sometimes some comorbid OCD, anxiety, sometimes maybe undiagnosed autism spectrum disorder. And so there's kind of a tendency already for mental rigidity that kind of sets them up.
Yeah, I would agree with that.
And I have a question. So we've been reading a lot around that since with COVID, and that there seems to be an increase in eating disorders. Do you have any comments or any information on that at all? And you might not, because it is so new, I realize.
We can't share specific numbers, of course, but certainly across the province, we've seen an increase in specifically child referrals. But I think that also for adults, but certainly, yeah, it's hard to say what the impacts of COVID have been. There's many studies out recently on the impacts of COVID when you look, you know, across the country and even throughout the United States. And I think one of the biggest things that happened with COVID is that a lot of kids were really focused on their extracurriculars. And when the extracurriculars got pulled and they already maybe had some like early signs of an eating disorder, were using the extracurriculars to make them feel better about what they were eating. When that stuff got pulled, then the behaviors kind of escalated in a different way. It seems like it's like almost like COVID was like the straw that broke the camel's back, for lack of a better way to describe it. Like all of their other mental health concerns. And then, you know, they already had some pre-existing stuff, and then it kind of was the catalyst.
And I think for some of them too, I think it's, you know, we talked about with younger kids, especially that kind of some comorbid conditions that would make them more prone to rigidity or wanting a lot of structure. And for those kiddos, I think it was really hard because they didn't know how to fill their days. And so they started filling it with trying to like get healthy, and then went overboard with it. So I think that happened, but I think it's also important to say a couple things about that in terms of the spike, which is one, we saw a spike in our referrals at the IWK actually in the kind of quarter or few months leading up to COVID. So prior to COVID hitting, there was a spike. And some of the things that we've been concerned about are, you know, social media, TikTok, things like that, that could also be contributing and might just kind of be co-occurring. Another thing that's important to mention, because we do, you know, we know that there's certainly risks associated with COVID, but we also saw in our clinic some of our patients doing quite a bit better. With the lockdown, as stressful as it was for families, sometimes, because as we talked about with that family-based treatment, the role of the parents in monitoring is so important. And so those parents were now at home, and there were a lot of barriers that were removed in terms of monitoring. So before, maybe they'd say, well, I just can't get there for lunch. I can't supervise breakfast. I have to be out to work. And a lot of our families were suddenly able to do that monitoring. They're together all the time. And we saw that be really beneficial for some of our patients. So it's kind of, you know, for some it was harder, for some it was potentially a bit better. And I also think being at home for that time, there can be a spike in referrals too, because families are spending more time together and they're suddenly seeing something that they hadn't seen. Some of our kids, especially the ones who are quite athletic, they might have siblings who are athletic too. They have so many activities, and the family really doesn't spend a lot of time together at home. And so those things can be missed. And we've seen those spikes before we have certain times of year where Jessica would always notice there's a spike in referrals, and it's often after things like March break, because the family goes on a vacation together. They start observing some of these behaviors. They also see them kind of in the warm weather, maybe wearing more revealing clothing, and then notice a change in weight. So I think there's some of those factors too.
Thank you both. One more question. This person would like to hear more about the connection with DAL, if you can share details.
Yeah, so I guess like our connection with Dalhousie Family Medicine was that we only have it in one clinic in HRM, but it does help meet some of our need for folks who don't have family doctors. And the collaboration really was, we wanted to make sure, it's nice because DAL is also a teaching facility. So we also have the benefit of getting our family practice residents more up and rolling with eating disorders as well. So in exchange for taking, I think, like a patient a month or something, I think is maybe the agreement, that we would give them education on eating disorders every 6 months to make sure that they feel competent with it. So it was a memorandum of agreement and just as a trial, but it's worked out fine. It definitely has met our need. And certainly we're going, like, if DAL feels comfortable, it would be nice to be able to do similar things across the province. I don't know if that will be possible or not. But, and it doesn't even have to be them. It could be any family practice if they wanted to collaborate and just feel like they have the support and a larger maybe patient population that has eating disorders so that they can get the appropriate expertise. But I think also we really want to educate all family practice, folks, in whether they're nurse practitioners, family doctors, family practice nurses, so that they feel comfortable and competent in the management of eating disorders, because it's going to come across. And if they feel comfortable and competent, they also are the spot where it will get detected the earliest. So unfortunately, we don't have a solution for a lack of family doctors across our province. I wish we could clone them. It would be great. But certainly, hopefully our new provincial service will be able to at least make them feel a bit more supported as we roll it out. It's brand new.
Great. So I don't see any more questions. Does, oh, let me see here.
That was just me.
That was you with the toolkit. So that's great. So anyone can copy and paste that. So that's a great resource to have. Anyone else have any last questions for Bryn or Jessica? And or do either of you have any last things that you wanted to mention?
I mean, I guess one thing I'll say is we always welcome, questions or feedback from folks working in the schools about what we can do to support teachers. In particular, I mean, I think all teachers and folks working in the school, but also health teachers, phys ed teachers that might be kind of dealing with needing to make more accommodations for some of the students. So, we are thinking about some things that we can do in the fall as school gets back in session, and we always welcome any feedback or ideas about that.
Great. And someone in the Valley says there are resources created by the support group in the Valley for educators and doctors.
That's great. We'll get our hands on those resources so we can develop. I know the Valley folks are very eager, and certainly I think it'll be really good to be able to continue to support and share resources across the province so we can make things as consistent as possible.
Great. And you'll receive some thank you for presenting, and I also want to thank you. And it's been recorded, so it will be available at some time, not right away. Eventually, it will be available that we'll be able to share it with other educators and other folks in the schools so that they can see it as well.
Great. Thank you for having us.
Yes, thank you very much.
Great. Just getting lots of thank yous. So I think that would be the end, I think.
Okay.
Great.
Great.
Thanks, Tara.
Thank you, Tara. Bye-bye.
Bye.